like to introduce our next speaker, which is Clinical Associate Professor Tracy King. So I have known Tracy for many years. I think she's probably one of the my most long-standing colleagues in our unit. She's a myeloma clinical nurse consultant in RPA Hospital and recently made a clinical associate professor at the University of Sydney. She's also a research fellow at the Cancer Nursing Research Unit, Sydney University. She's had 30 years experience in the field of hematology and bone marrow transplant, having developed a specialist interest in myeloma 25 years ago in the International Myeloma Foundation, now Myeloma UK. And since then, she's been really active in multiple groups, including Cancer Institute New South Wales, the Myeloma Registry. She was a co-founder and past president of the HSANZ Nurses Group and founding chair of the Myeloma Special Practice Network of the Hematology Society. So she's going to talk to us today about understanding side effects of steroids with a very intriguing title. Thank you, Tracy.
Thank you so much, Joy, for that very generous introduction. And I hope to remember to tell you guys the reference to the wombats and the devils. And those of you that are listening in at home probably know who are the wombats and the devils, and you probably gave me the terminology for this talk. But my research focus is in that of supportive care. And when we talk about supportive care, means the impact of a diagnosis and its treatments. And a lot of that work is done in the space of looking at side effects of treatment. And with a myeloma focus, and I've worked in myeloma for 30 years or so, it's the steroid side effects that seem to have turned my patients into wombats and devils and many other beasts that has sparked my interest in looking into this area to see if we could identify what's going on in terms of steroid effects and actually work towards some interventions that can help people tolerate these drugs a little better. My colleague Christian Bryant did put this slide up, and it demonstrates that in myeloma, and this is the same in all cancers really, that new drug development has resulted in patients living longer, and that's a very important and good thing. So quantity of life is very important. But these drugs that we perhaps started to use when we first treated myeloma, these steroids, which my patients call the devil's tic tacs, hence that word, have been with us since we started treating myeloma and endure to this date. And they're very important in the treatment of myeloma. They're very effective in treating myeloma, killing myeloma cells, and in combination with the other drugs, make the treatment work more effectively. So they're not going anywhere. But why are they called the devil's tic tacs? Let me just take a minute to talk about and describe what we mean by quality versus quantity. It is commonsensical in that quality of life talks about what matters and brings meaning to life, and that's very an individual thing. And quantity talks about the length of life and the survival, and both are equally as important. And I think when we first spoke about quality of life in healthcare, the World Health Organization in the 1950s began to define it as not merely the absence of a disease, but we know it's more than that. It's a multi-dimensional concept. It includes aspects and experiences relating to not just the physical, but the mental, emotional, functional, social functioning and role functioning, in addition to just the disease and the impact of the disease and treatment. And more recently, just in the last decade or so, we've began to understand in health research that the patient self-report is most critical, because what brings meaning to our life is very subjective. It's different to me, it's different to Joy, it's different to all of my colleagues and to every one of you. So the subjective nature of quality of life is important. Therefore, it must come from the person who it relates to. So we have used the term now patient-reported outcome to describe quality of life. And once we've defined these concepts, we can now measure them. And Susanna spoke very nicely about some of the techniques to look at how we measure peripheral neuropathy. And we can do that with all symptoms and experiences and side effects. And that's where my research fits in. And this quality of life research and measurement and data helps us as clinicians, in addition to response and survival data, to help improve the lives of people living with blood cancers and other illnesses. So the devil's certainly in the decks, and my interest, as I said, has become, I've been looking after myeloma patients for decades, and consistently they've been reporting to me very similar problems with these devil's tic tacs. These steroids, aside from the side effects of all the other drugs, seem to cause some of the most significant side effects for patients, and they can be very, very hard to tolerate. So my research looked at better understanding the impact of these drugs in patients with myeloma, and to develop an assessment tool or a measurement tool, which we call a patient-reported outcome measure, to do just that. So for those of you that might not appreciate how much steroids we use in myeloma and in other blood cancers, in myeloma particularly, they form part of every drug regimen. So people with myeloma may be taking steroids for many, many years. The side effects can be acute or chronic, and not only impact a patient's physical symptoms, such as can cause high blood sugar and irritability to the stomach, can cause difference in energy, and fatigue is a big issue as well. But they can actually change people in regard their emotional and behavioral effects. They can cause some irritability and some anger, and that can be very hard for patients' relatives to tolerate as well, of course. And we know that the use of steroids in myeloma has changed, and we use a lot less than we did, because a study in 2010 by Vincent Rajkumar, which was published in a very well-respected journal, demonstrated that when we use very high doses of dexamethasone, 480 milligrams a month, which is probably, for those of you listening with myeloma, 40 milligrams 3 times a week, 3 weeks out of every 4, it's a lot of DEXA, that people had worse outcomes. They had more infections, and actually some people didn't live as longer by taking more of a drug. And so it caused a change in practice, and we now use a lot lower doses of dexamethasone. And I'm sorry to say that 40 milligrams a week is a lower dose. And indeed, we use even lower than that. So we need to balance the treatment efficacy, getting rid of the myeloma, with the toxicity and the side effects. And we know that patients were saying that these drugs were hard to tolerate, but nobody had actually ever done any work in this space to describe that or to measure for it. And so that's where this particular study came in. The study had 4 phases, and I'll describe them very, very briefly. The first was to look at the literature and find out what was already known. And we found pretty much nothing in the myeloma space looking at steroid side effects in myeloma. So the first part of our study, we needed to talk to people who were impacted. So we did a qualitative exploration with patients, their family members, and doctors, nurses, and psychologists. We had diary keeping periods and journaling, and I did a lot of interviewing, and I was able to thematically analyze all that information, to be able to start to report what was going on for patients. What we found was that steroids certainly change people, and these are some of the quotes that my participants reported. I'm sure they'll probably resonate with some of you listening to this now. Steroids are like a truth serum. I'm just not a nice person. Some people did find that there was some positive aspects of being on steroids, in that you can get a lot more energy and be energized. What we did find, though, that sometimes this energy is not actually very useful, and it might help you walk around a field several times, but it's not going to help you get on and function and do your work or look after your family. We certainly found very strongly that people really didn't like the steroids and that they were most troubling. We also interviewed doctors, nurses, and psychologists, and we found that they supported these claims too, that their patients did find steroid drugs very hard to tolerate. They weren't sleeping very well. They had problems with needing to dose reduce these drugs very easily and very readily. And people could even have emotional or even psychotic episodes on these drugs, which were very hard on those living with people on steroids. Our psychologist even shared with us that when she saw patients, they often felt they were going quite mad, and then they were quite relieved to find it was the dexamethasone that was causing these side effects, and they were somewhat relieved by that. So the next step of the study was to develop a questionnaire that could measure effectively for these impact, for these side effects. And there was a short questionnaire that was developed in other cancers to look at dexamethasone when it was used in very small doses as an anti-sickness medication. So we started with that tool and we adapted it based on all of the findings from our previous phase of the work. We came up with a questionnaire. The questionnaire could have been 30 pages long, but we did have to get down to about 20 questions that were most meaningful to patients and that were amenable to intervention, that we could actually make a difference with them. And then we went ahead to test that in a cross-sectional study where we had patients completing the symptom questionnaire to find out what the burden of these steroids was. I mentioned this questionnaire, or patient-reported outcome measure is what we call them in research, had 20 questions, and people answered these questions on a scale of not experiencing that side effect through to having it very much. And the total scores, the higher the total score, explained a higher symptom burden. We asked people to reflect over the past 7 days so that we could capture some of these symptoms that only occurred on the steroid day. And this is pretty standard in quality of life assessment tool research. We also asked people to list any other problems so we could capture those effectively. I'll briefly show some of the information here. Just shows that the group that we tested were pretty representative of people with myeloma in their high 60s. We had men and women and a range of experiences on how much treatment they had had. We found captured information on the dose of steroids they were taking, and we do use up to 40 milligrams a week, if not higher, and most of these patients were taking a lot less than that, which is reflective of the real world use of doses of steroids being a lot lower. What we were able to demonstrate, which was very nice because this is the first time this data has ever been reported in a research study, is that there was the frequency of these symptoms and the severity together means symptom burden. And we were able to demonstrate the high symptom burden for patients when they're on dexamethasone. And I'm sure, again, that resonates with those of you listening in. Disturbed sleep was the most significant, and the vast majority, 95% nearly, experienced disturbed sleep, and 70% nearly in a severe form of disturbed sleep. Loss of energy and fatigue, and this agitation and nervousness or discombobulation that people described to us was also very significant. What was significant were the number of separate side effects people were experiencing. And don't forget, we were just asking them about side effects related to dexamethasone. This didn't include their neuropathy and all sorts of other side effects they may have as well. And the number of severe symptoms they were experiencing were also very, very high compared to side effects experienced by other drugs. We were able to, in the journaling, demonstrate that these symptoms, and if you see in this scale here, along the bottom, we have a number of weeks. And people were keeping a journal for several cycles of treatment. And 0 to 5 was the severity of the symptoms of high energy, difficulty sleeping, and increased appetite. The black star here demonstrates a dose of dexamethasone. And you can see here very clearly that these symptoms were closely associated with the dosing of the steroid. And again, that was the first time we've been able to demonstrate that for the first time in the literature. So very briefly, the symptoms people did experience are listed here, and I'll just get you to focus on disturbed sleep being in the majority of patients, and that's not new to any of you, I'm sure. But what is also important here to notice is that most people experienced all symptoms and at a large percentage. And that's quite unusual when you look at symptoms associated with other drugs and the frequency of those. when we look at the severity of symptoms, we often use 10%, which is reflected here with a blue line, to show symptoms of concern. And you can see that most of the symptoms related to steroids are quite concerning in terms of their severity. Again, this is all information that's not been reported before this study. So finally, what are we doing now? We're taking this information forward in this questionnaire, and we're actually doing some psychometric testing, which looks at the reliability and validity of the questionnaire in a larger group of patients. And we're doing some concurrent health-related quality of life assessment, and some of you have completed that, and I'm very thankful for the time you've taken to do that. We've also been contacted by researchers in the Nordic myeloma group, and they are translating our tool into Finnish, Danish, and Norwegian, which is quite a process, and I've been involved in that, and that's been very interesting. But pleasingly also, we're now, like Susanna was telling us, the important thing about when you find out something's a problem and you start to be able to define it and measure it, you need to work towards improving it. And what we're doing now, thanks to some funding from Sydney Blood Cancer Research, is to do a study where we're going to, again, for the first time ever in myeloma, characterize this nature of sleep disturbance. We've got some cool wrist actigraphy, ActiWatches, which are wearable devices, and we're going to be interviewing patients and doing sleep diaries to evaluate sleep quality in people with myeloma on steroids. And from that findings, we hope to be able to develop some interventions to help people sleep better. And we're doing that in collaboration with the RPA sleep scientists, Dr. Kerry Mellahan and her nurse consultant, Ghislaine, and of course with Professor Kate White from Cancer Nursing Research Unit. Yes, I forgot that little fellow was going to bob in there. So hopefully we'll have you sleeping better soon with the results of this research. So I'd like to leave it there, Joy. I'd just like to thank, this work was done as part of my PhD studies. I'd like to thank my supervisors, Kate White and Doug Joshua, and all the others involved. And of course, patients, wombats, devils, and all sorts of fantastical beasts that inform me of all this great data. Thank you so much.